Welcome everybody to our ongoing series of webinars around the corona virus pandemic and COVID-19. Today we are going to have what I believe is going to be one of the most interesting discussions we've had to date, and that's because we do see a silver lining amongst all of these clouds. We're really delighted to have back with us Dr. Bernard Camins, who's professor of medicine and infectious diseases from the Mount Sinai Hospital System in New York. As I'm looking at Dr. Camins on the screen, I'm reminded that I think you were a presenter in our very first webinar back in February. It feels like 5 years ago, candidly. And I'm happy to see that you're with us and healthy. And I know that the system has gone through a lot of turmoil in the past 7 months. So welcome and thank you again for this interesting discussion. And Dr. Cara Pensabene, our own medical director here at EHE Health, who's going to discuss and walk through a short presentation on where we are with respect to the coronavirus vaccines and monoclonal antibodies. I know, and we all know, that we're really in a very bleak period here in America with respect to this pandemic. Cases are exploding all over the country. Hospitals are becoming overwhelmed once again, less so overwhelmed in New York. We've seen the brunt of it back in the spring, but obviously we're cautious in other cities, but we can certainly empathize with the anxiety and the fear that's going on in the rest of the country. Today, I think we're going to have a little bit of a different discussion. And we're going to talk about science and the art of the possible, and finally bringing this pandemic to its knees and getting out in front of it. And with that, I'm going to pass the screen, as we say, to Dr. Pensabene. We will go through a short PowerPoint to tee everybody up, to give everybody a baseline on what we're exactly talking about with respect to vaccines and monoclonal antibodies. And then we're going to ask Dr. Camins several questions and to comment, as he is in charge of the deployment of these vaccines and therapies for the hospital system, and as an inside view on what is likely going to happen over the next few weeks and months. So with that, I'm going to pass the screen over to Cara. Dr. Pensabene, thank you.
Thank you. Good morning, everybody. Vaccines, as we know, typically require years of research and testing before reaching the clinic. But this time, scientists have been racing to produce a safe and effective corona vaccine before the end of the year. Researchers are testing currently 54 vaccines in clinical trials on humans and at least 87 preclinical vaccines that are under active investigation. Work began back in January when we originally deciphered the SARS-CoV-2 genome, and the first vaccine safety trials in humans started in March. Now 12 of which have reached the final stages of testing. Some of these trials will fail, others may end without a clear result, but several vaccines will succeed, which we are already seeing in stimulating the immune system to produce effective antibodies on the virus. And the next slide shows 5 of the top vaccines that we've been closely following that have already reached these phase 3 trials in humans and are nearing the finish. And in a phase 3 trial, scientists give the vaccine to thousands of people and wait to see how many become infected, compared with volunteers who received a placebo. It's these trials that determine if the vaccine effectively protects against coronavirus. And those of us may remember back in June, when the FDA advised vaccine makers that we wanted to see, the number we wanted to see was at least 50% evidence that these vaccines can protect those who receive it. In the past 2 weeks, we've heard about early results from the top 2 vaccines that you see on this table, Moderna and Pfizer, both showing very close to or 95% efficacy. These are both mRNA vaccines, which means that coronavirus genetic material is what's injected to provoke the immune response. And they do need to be kept cold, frozen, one of them colder than the other. But 25 million doses are expected to be available by the end of the year, and billions more produced for next year. And then the other promising phase 3 trials in the other 3 rows in this table, to watch are Johnson & Johnson, which will likely see results in the next few months, AstraZeneca and Novavax. And none of these require the cold chain infrastructure of the Moderna and the Pfizer. And there are different types of vaccines. J&J and AstraZeneca are viral vector vaccines, which use a weakened version of a common cold virus to bring in the coronavirus genetic material and provoke that immune response. And the Novavax is a protein-based vaccine, which means that it's actual coronavirus protein and not genetic material that's used to cause the immune response. And all of this is really exciting. And on the next slide, we will see why vaccine distribution, if done well, could really be one of the silver linings that Dr. Levy was speaking about in this pandemic. It's really a matter of math. So far, there have been 11 million cases of COVID-19 and 245,000 deaths. And we know that 95% of the COVID-19 fatalities have been in high risk or vulnerable people. And these are the people that are going to be prioritized for vaccine administration. As we just saw in the last slide, the first 2 vaccine phase 3 trials are showing 95% efficacy, which theoretically means that we could reduce the lethality of this epidemic by upwards of 90% by immunizing all of those that are at high risk of developing severe COVID-19 with the active immunity from vaccines. And we know that the case fatality rate, we see different numbers, but an estimation is really to be about 0.5 to 1%. And with optimal coverage of these vaccines to these vulnerable high-risk populations, we can reduce that drastically to 0.05 to 0.1%, which is comparable to the case fatality rate of the seasonal influenza at 0.1%. So in short, the potential for the epidemic impact is large by immediately targeting these vulnerable populations with active immunity from the vaccines. Next slide. And we know that a vaccine will help protect individual patients and those around them, but that a large population a large proportion of the population must be immunized before we can reach that herd immunity and substantially reduce transmission. Although no company has yet received their emergency use or their EUA for a vaccine, we know that this is imminent, and production has already been ramping up due to pre-purchase commitments by the federal governments. We know that millions of vaccines plan to be available, before year's end. And again, we're going to prioritize those to the 30% of the population that is at high risk of dying. We do know no vaccine will be 100% effective. And again, the progress towards herd immunity will take time. But what we will see in the shorter term is a significant impact on the lethality of the epidemic, the hospitals, the ICU bed supplies where Dr. Camins works. And we can see this sooner rather than later if we are very efficient and clear about distribution and really our acceptance as a public about this vaccine. Those are key factors to the early success and getting this short-term impact. And just a reminder, effective public health measures, social distancing, small gatherings, wearing masks are going to be needed for several more months after the vaccines are being administered. But we really see this silver lining on the horizon to reduce the lethality. And we see an even more immediate silver lining on the next slide, which is monoclonal antibody treatments. And antibodies, we know, are naturally made in our bodies to fight infection. And whenever there's a foreign invader in our body, our immune system produces antibodies that come and attack that invader or foreign substance. So that way it remembers it. And the next time that it shows up, the immune system can produce those same antibodies and help fight it off before it makes a person sick. And these types of naturally occurring antibodies, due to just exposure, provide active immunity. And as we just learned, vaccines work in a really similar way. They help make antibodies to attack the specific foreign substances or viruses and provide that activated immunity. Antibody drugs are different. They're man-made antibodies that are given directly into the body, rather than prompting the body to make the antibodies for themselves. This type of immunity is called a passive immunity. And, monoclonal antibodies are a class of medications that have transformed the way we treat and prevent diseases, from cancer to immune system diseases to childhood viral infections. The first monoclonal product was licensed more than 30 years ago. And since then, we've seen people benefit from more than 100 different types of treatments. And it's one of the fastest growing and most promising fields in biomedical research. So much so that last year, 7 of the top 10 top selling medications were actually monoclonal antibodies. And since the start of the pandemic, just like the vaccine research, scientists have been rapidly evaluating not only existing drugs, but developing new treatments that include monoclonal antibodies to help treat these COVID-19 patients. And more than 70 monoclonal antibodies are in development that specifically target the SARS-CoV-2 virus. Typically, monoclonal antibody treatments are given through an intravenous infusion, IV, into a vein or an injection. And the frequency depends on what we're treating in the specific monoclonal antibody. Side effects can be common, but they are short-lived. And they can include allergic reactions, flu-like symptoms, upset stomach, low blood pressure. But again, another silver lining is that we know this is a way we can tell the medication is working and is effective. So last week, we heard about the pharmaceutical company Eli Lilly in collaboration with AbCellera that received their FDA emergency use authorization for bamlanivimab. And that's the first monoclonal antibody to treat COVID-19 that got that EUA. And it's authorized to treat mild to moderate COVID-19 symptoms in both adults and pediatric patients who weigh at least 88 pounds and again are high risk of progressing to severe disease requiring hospitalization. And when you review the emergency use indications, we've summarized them on this slide. And really the silver lining again is that 30% of these Americans meet these high risk criteria for receiving the treatment, which includes, anybody 65 and older, anybody 55 and older with high blood pressure, heart or lung disease, people who have diabetes or kidney disease, those of us who are severely overweight with a body mass index greater than 35, anyone on immunosuppressive treatments for cancer or arthritis, and a certain high risk group of pediatric patients, including those that have moderate to severe asthma that require daily medications. The Eli Lilly trial showed that their monoclonal antibody treatments reduced hospital admission rates in these high-risk groups of people that you see on these slides by 70% if given before hospitalization when the symptoms are still mild to moderate. The potential epidemic impact of targeted monoclonal antibody treatments in this population is quite significant. And to date, we know, as Dr. Levy said, there have been 11 million cases of COVID in the United States, over 245,000 deaths. It's looking pretty bleak out there. But as we've already pointed out, we have the math. 95% of these fatalities have been in the high-risk groups, those that are indicated for the EUA. And again, reminder, these studies with Eli Lilly, they're showing that the monoclonal antibody treatments reduce our hospital admissions in these groups by 70%. So just applying the math, if there was the appropriate supply for the high-risk group of patients and it got to them when they needed the medication, it would be theoretically possible that we reduce the lethality of this epidemic by 2/3 just by getting the treatment to the vulnerable, knocking that fatality rate of COVID-19 down from the estimated, again, 0.5 to 1% to 0.17 to 0.34%, which is so much closer to that seasonal influenza fatality rate and really the goal with the vaccine. So in summary here, the potential for the epidemic impact in this short term is large and quite hopeful. And, we spoke about Lilly that received its EUA last week, and we know immediate distribution is going on with another company, that has imminent approval for their medication, which is Regeneron. And, a reminder in the press here, Governor Christie had received the Eli Lilly medication. President Trump received the Regeneron treatment. Both are doing quite well. And at best, we're going to have a few 100,000 doses available for use in the next few months. And again, we need to give this medication through an IV in an infusion in a center that is set up, an equipped center. But we can do this right. The math is the silver lining here. High-risk individuals, the 30% of our population, with 1 million cases that we're seeing a week, we need to understand how important this is. Every 1,000 doses of a medication like this could potentially avoid 700 hospital admissions right now. For my colleagues in the hospital, for Dr. Camins' team, we know how much this will put a dent in the crisis of not only the hospital surges, ICU bed availability, but our economy as a whole. And this is about the allocation, an example of how we hope to get the medication to the vulnerable population. And it starts out with the government. They've purchased 300,000 doses and committed that Americans will have no out-of-pocket costs for the medication itself. But some facilities, of course, may need to charge a fee, given that it requires equipment and staffing. And the government is who is going to allocate the medication, with weekly decisions being based on the COVID-19 cases in the states and territories over the previous week. And then each week, the health departments, the state and local health departments, will select the sites of care. Hopefully Dr. Camins will share more about what some of those might look like, that are accessible and then can minimize this infection transmission. And those sites will receive the allocated doses. To receive the allocated doses, they'll provide the distributor the list of sites from the health department. Then the distributor will ship the medication, in theory, at least as per this flow, overnight right to the treatment centers. And there's been large scale investments in manufacturing of these medications at risk, even before the data really showed its potential. And we do have a robust global supply chain from Eli Lilly in place to produce the medication with numerous manufacturing sites worldwide. They hope to manufacture up to 1 million doses by the end of 2020, and it will be globally available in the beginning of next year. And Regeneron, their EUA is imminent, again, along with several others that are nearing their trial results. So these monoclonal antibody treatments, they're not only a silver lining, but they are an important, critical stopgap in protecting our vulnerable populations, avoiding hospitalizations, and taking some of the pressure off of the vaccine.
Super, Cara. Thank you very, very much. Dr. Pensabene has worked as our lead physician on the coronavirus response for EHE for the past 7 months, and we're getting there, I would have to say. This is a much better discussion than we've had, I would have to say, in the past few months.
Definitely the most enthusiastic I've been. Thank you, Dr. Levy.
That's great. So look, I'm going to start by being a little bit provocative with Dr. Camins about the math. And then maybe you could just address where my math is wrong here, and then tell us how Sinai and the rest of the hospital systems are preparing for the coronavirus vaccines, as well as the monoclonal antibodies. But the way I look at this is when you have a highly effective vaccine with an efficacy of 95%, and you target highly vulnerable populations. And we know, for example, 80% of all fatalities of coronavirus happened in people age 65 and over. If we were just to apply any one of those, either of those two vaccines to everybody in America, 65 and over, we would take down the lethality of the epidemic by 75%. And candidly, the way I look at it is that if in fact we had supply and we mobilized the National Guard in every state, and every healthcare provider worked through the entire month of December, getting everybody theoretically over the age of 65 immunized with one of these two vaccines, the hospital crisis on January 1st is over. Tell me where I'm going wrong here, Dr. Camins.
No, I think that those are really good points, right? And I certainly agree with it. And the only thing is that we would have to temper that only because it is theoretical, right? So number one, that is assuming that we have 100% acceptance rate of the vaccine, right? Which unfortunately, with the mixed messaging that we have gotten, or the public has received, that we are, I would say, we're probably only about, I think there was a Gallup poll that showed that only 50% of Americans were willing to even take this vaccine, which is a lot lower than other countries, right? So unfortunately, that is the issue. And again, the Pfizer and Moderna trials with the 95% efficacy includes all ages. And so one thing we could also say is that the higher risk population may have weaker immune systems, so they may not respond to the vaccine as much, right? So they might be, more of them might be skewed towards that 5% where it doesn't work as well. But just like the flu vaccine, the high risk population, even though flu is not as effective in their situation, it may actually prevent them from getting severe disease as well, right? So it doesn't mean that it won't protect them 100%, but it also means they might end up with a milder disease than expected, right? So I think you make a really good point. If we have enough vaccine and we mobilize everybody and concentrated it on the administration, it will put a huge dent in the number of people in the hospitals, right? The number of people who need to go to the hospitals, and it may just then potentially be equivalent to what we see during the seasonal influenza like season, right? So it'll reduce it to that much. But even if we double, let's just say, even if we're double the number of seasonal influenza cases that come into the hospital, that's still a drop. Still significantly much lower than the current process. I mean, yeah. So we're in dire straits in terms of some of the hospitals in the Midwest are even discussing going into crisis standards of care, right? Meaning, I hate to say this, but some of them are thinking of rationing care, right? By rationing, meaning that they don't have enough ventilators or they don't have enough ICU beds, right? So those are, it is something that we are trying to avoid in the New York area, and I'm really hoping that we're able to do that.
I was asked, I did a short radio interview a few days ago, and I was asked about this, and particularly about this issue of coordination and distribution. And I try to answer the question purely as a public health person. And I think that all public health people have to reinforce this message that nothing is as important in the next 6 or 8 weeks as a coordinated, smooth national effort to distribute and to vaccinate and or provide monoclonal antibodies. We can put an end to the hospital crisis within weeks if, as a country, we rise to this challenge and get this thing done. And it's really within our sights. I mean, we all were thrilled when we saw 95% efficacy. I actually thought it was going to come in at 70 or 80%, as many others thought. I mean, 95% for people is like a measles or a polio vaccine. It is highly unusual.
Agreed.
And so it is. So this really dents it, and it dents it quickly. So
and I agree, Dr. Levy. I was actually trying to think it was somewhere going to be between flu and measles, which is 60 versus 93%. So somewhere in the middle was 70, 75. But then it is an mRNA vaccine, which we have never seen before, right? So that is potential the reason why.
So now tell us the inside story, if you can, about what's going on in the Mount Sinai hospital system in New York. I'm sure this is going on all over the country. both with respect to the vaccines and the antibodies, how you're preparing, when you expect supply, what you guys are going to do, on day one. And day one could be as early as next week. Well, I think the monoclonal antibodies are already approved, and we may be past day one. But what's going to happen when the vaccine hits? And tell us how that's all working.
So the monoclonal antibodies, I think we, as Dr. Pensabene showed, that the allocation is based on the number of cases the week before, right? So New York, as far as I've heard, it's not necessarily confirmed, was only getting the state anyway 2,000 doses of the antibodies because we do have really low number of cases. So, but it is already available, and I think the indications were reviewed. And so it is not for everybody. You would have to be in the high risk category to be able to get that treatment. And I think, the one thing I do want to caution is that it is in the person's best interest, if they are at high risk and gets diagnosed, that you do get that treatment within 5 days of your symptom onset, right? Because there's actually the reason why this is given early is that once you form your antibodies, it's too late, right? So in fact, there's some data to show with this antibody treatments that if you get it too late, it may actually harm you than help you. So, so within 5 days of your symptom onset, you do need a diagnosis, preferably, by PCR because it's more sensitive of COVID-19 or SARS-CoV-2 PCR, and actually that's how you would meet the criteria. Right now, the plans are to do this, since it's only one infusion, would be to do it in an infusion center, very similar to where patients get chemotherapy. But then that's always the issue, right? So we've been treating patients with cancer with chemotherapy still. So we actually have to make extra space, and we have to keep them really far apart because the patients who are getting these infusions are infected with COVID. And so it may be limited to the number of the places where you can get them. But certainly in our plan for Mount Sinai Health System is that we are going to have it available at 2 different locations to start with. And well, 1 first and then 2 eventually, and then see, the supply. I mean, if we are limited to how many doses we can have access to, then there's no point in opening it, making it available all over. The person then will just have to travel to 2 of our locations, and we're still working out the mechanism on how to for primary care doctors to refer somebody, a patient potentially, to then get to get the treatment. But certainly it will happen in an infusion center, the same centers that actually provide chemotherapy to our patients. And it may be at certain hours, right? So, because again, we want to make sure that there are no other patients in that infusion center except for people who are COVID positive.
So just to get practical on that, let's say I'm a vulnerable person and meet the definition. I have a fever, temperature, PCR positive. Do I go to the emergency room at Sinai? What do I do? Do I call you up on your cell phone? Can I distribute your cell phone number to all of
at this at this time, I think going to the ER, people can be referred from the ER if they do meet the criteria, and then they get referred, and would be okay as well. Eventually, I think we will have an access number, right, to call through the access center and have the primary care physician uh, refer the patient, right, and then they would review it, review the situation, and review the case, and then if they meet the criteria, then you say come on over, right? So, and again, because there is time, right, that you have within 5 days to get the infusion. The infusion center will not be open 24 hours a day. It'll be open on business hours, and maybe just 1 day over the weekend, and not be open every day.
So just to stay for a moment before we go to vaccines, just to stay on the antibodies for Dr. Pensabene, we've been planning at EHE Health for our clients, we've been thinking through the availability of monoclonal antibodies. And I know you've been kind of exploring how to, connect our patients and our clients to that. What's the progress so far? Can you give people a kind of a sense of what we're thinking about?
Yes. So at EHE Health, given that we are preventive healthcare experts, we understand which of our patients and our employers, our clients' patients are vulnerable and will meet that risk for, high risk criteria or for treatment with a monoclonal antibody. And we also understand that we are in a wonderful position to help provide access in a streamlined way. Similarly, David, to how we set up our COVID-19 hotline, early in the pandemic, where we were able to provide not only access to local testing centers, but to all COVID-19 resources available to our patients across our national country, our national network. So our plan is to understand who's vulnerable, encourage our patients to get their preventive exam, identify their risk, provide our hotline where we can get quick access to testing and the results to keep that 5-day window Dr. Camins is talking about, and then have a map of these infusion centers and be those primary care doctors or those preventive healthcare specialists directing our patients, our family, our members and friends to the centers in that timeline. So we can be a big part of the solution, David.
And actually, Dr. Levy, if you have a client and they go through you, you are free to call me and I will connect you to the right person. Yes.
Uh-oh.
So,
I don't know if you know what you
until
just
the new until we have worked out the whole protocol, and I will and I think we received the first shipment I believe Tuesday. So it's really, pretty much hot off the presses, right? So and it is complicated. We have to create a new order set with electronic electronic medical record keeping, all those things that we have to work with IT. So all those things have to be worked out. But certainly, if you do have a client who needs it, please feel free, and I will connect you to the right person. So.
Thank you. That's really gracious. Thank you very much. So let's turn to the vaccines a little bit now, because it's, here, they're not quite yet approved. We know they're in production. What are the plans at Sinai? How is this going to kind of work out?
So, and I think it's important before we go to that, right? And we do need to, I think, explain to the audience that an emergency use authorization doesn't mean that, it's being approved without any data, right? So there's going to be data available. It'll be presented. The only difference between an EUA and a full licensure is that the safety data of a year or year's follow-up, right, is the difference. So we, at the most, when Pfizer or Moderna submits the data to the FDA, they will have 2 months worth of safety data among all their research subjects. So that is one, but it doesn't mean that it's not safe, right? Because they have studied it in 44,000 people, at least one of the studies. So it is, and there are really so far as we know, no life-threatening side effects, but there are some significant side effects, which could be just fatigue, right? But that actually is showing that it's working. It means that your immune system is being primed. So then you have lots of antibodies then to fight off a real COVID-19 infection if you were to get exposed. So what are we doing? Well, the first thing we had to do was actually purchase minus 70 Celsius freezers, right? So these are freezers that are normally used only in the research world. So they are available, but they're not in high demand. So I know that there will be some institutions who are ordering them, but yet will not get their freezers. The one thing we did was we ordered them in anticipation of this of the vaccines being available. The difference between the Pfizer and the Moderna vaccines is that the Moderna vaccine seems to be a little bit more stable in warmer. When I say warm, it's still pretty cold. It has to be at -20 Celsius. But some of our regular freezers can actually achieve that temperature. So the Moderna vaccine doesn't have these really high, really finicky requirement for storage. And so what will end up happening for the most part is that the Pfizer vaccine will probably be more available in the urban areas, so high population centers, only because the other part is that you can only order in 1,000 doses and 1,000 doses, and so you don't want to waste it. So if you are a location where you only need 100, that will be potentially 900 doses that you can't use. That once it's thawed, you only have 5 days really before
Mhm.
you have to distribute it. So what we're doing then is preparing first the phase. I think someone asked in the chat, like, who are indicated for this vaccine. Actually, uh, at least we know maybe not the really really young kids, but but certainly pretty much everybody, right, should be getting one of the vaccines when it's available, because we do want to try to get as high acceptance rates as possible. But right now, the way it's working out is that frontline workers, so healthcare workers, will be in the first wave. And even in those situations, since they're going to come in drips, meaning we're probably going to get 10,000 doses at a time, that then we, even among our own frontline workers, we will actually also prioritize them. For example, ER physicians, nurses, ICU nurses, physicians, respiratory therapists will also get them ahead of time. And then, dentists actually, they do a lot of aerosol generating procedures. So we're definitely going to include them. And then eventually, once you have the healthcare workers, and that then will include nursing home healthcare workers as well, potentially, then we will then have the second tier would be patients, right? And the higher risk, probably the same list that qualifies for the monoclonal antibody, will be the same risk factors that will get the first wave of patients being vaccinated. So anyone older than 65, right? So will probably be able to access it. And again, we've because of the way the vaccine is, this is one of those where you really have to make an appointment and allocate a vaccine to that person, and then even have a wait list, right? So in case that person doesn't show up, we will probably have to call the second person. It's like, hey, this person didn't show up, because we don't want to waste the vaccine. So all those things will have to coordinate with the Pfizer vaccine. Now, our plan, uh, we have obtained -70 freezers at all our hospitals, and just because that's where we can have them stored. So a lot of our vaccine distributions will probably be centered around our hospitals, which are all over the New York area. So we have one in Long Island as well. So, but most are in New York City. So that's probably how it will be. And again, we are just not going to vaccinate our own patients. We are planning then to be a vaccination center for everybody, and we'll work it out in terms of scheduling, and we're all doing that right now. So we're busy working with IT, and to get the order sets as well.
So, do you think there will be designated hospital systems in urban areas, or will multiple hospital systems, for example, New York is Columbia,
Mhm.
and others doing the same thing, or there's going to
I
be, yeah.
Yeah, no, so that's a really good question, Dr. Levy, is that I'm actually in conversations and regular meetings with the Department of Health, with this, particularly the city, because a lot of our hospitals are in the city. But in those meetings, the other healthcare centers, the large healthcare centers such as Northwell, NYP, NYU, Montefiore, they're also in those meetings. And so, and we are all also comparing notes, right? So a lot of the prioritization lists, it's already has been released by NASM, but chances are the ACIP, which is the which is part of the CDC, which makes recommendations for vaccines, will likely bring publish their recommendations as well as the who should get the vaccine first, and we will most likely just follow their recommendation as to creating that prioritization list. But all the rest of the healthcare systems have also started purchasing the -70 freezers as well, and so we will and again research. It's these freezers are available at research centers, and so that was our backup, right? In case we couldn't if in case there's a shortage, we would have tend to use research freezers, but we were able to get our supply of -70 freezers. So.
That's great. I'm going to ask you just one technical question, then I'm going to go to the chat and ask.
Uh-huh.
This is just a technical question. You have to have 2 doses, right, for
Yes.
both the Moderna and the Pfizer vaccines. Does it have to be from the same? Is there a specific technical reason what it has to be from the same lot, or is it a different dose, or you can just go in 2 weeks apart? In other words, you have to be tracked to the 2, and then you have to be tagged to a specific lot number. I mean, is there another complication around the second dose?
There is a complication, not necessarily by lot number, but you have to get the same vaccine. Both Moderna and Pfizer require 2 doses. So if you receive the Moderna vaccine first, you should then receive the Moderna vaccine the second time. And the complicating issue is that one of them is 21 days apart, the other one is 28 days apart, right? So that's another that could complicate things. But I have to say, I'm very I'm happy that New York State has a really good immunization records database already. It is not required for adults for any adult who gets a vaccine. They have to consent for any healthcare provider to submit their vaccination records to the state. But for anyone younger than 19 who receives a vaccine, it is by law that they have to report their vaccination. And so the infrastructure is already there, right? So part of this then, when we vaccinate either with the Moderna or Pfizer vaccine, part of the consent is that you're going to either, we will get a blanket, at least for a coronavirus vaccine that then you don't need a consent. We will be regulated by New York State to actually submit the data, or as part of your consent to get the vaccine, that you will also consent to your information being shared to the state health department. So then everybody can access. So in case you got your first vaccine at Mount Sinai and decided to schedule your second dose somewhere else, which I don't recommend, but if you decided to do that, your provider can look up when you got your first vaccine, your first dose, and what brand you got. And so they will be able to give you the right second dose.
Okay, so I'm going to go to some questions here. I won't take them in the order I got them. I'm going to try to join up some relevance here. So really interesting question is, how much vaccine hesitancy have you been seeing amongst your medical staff? Because I admit we've seen it at our own medical staff, and I think we can be honest, right?
Yeah, no, I can honestly tell you, I'm surprised, considering how bad this pandemic has been, that it's equivalent to 50%, which is the same as the hesitancy for flu vaccine as well, right? So you would think that it should be higher, but we're seeing the same thing. And unfortunately, it's the mixed messages that they've gotten, and so we just have to reassure them. And I think your idea, Dr. Levy, about taking a picture while you're getting the vaccine would help. And so we're probably going to do that. I've done that intervention with flu before. There's no reason why I can't film our CEO and our hospital presidents taking the vaccine, so our healthcare workers can see that, you know, that they themselves are taking the vaccine. So,
you know, we've encountered that here, and I said to our staff, look, I'm a quote vulnerable population. I don't actively see patients, but I fall into a category. And I'm just going to sit down and I'll be the first one, and everybody will take a movie and we'll show it that it's okay.
it's
And
okay.
and in our next webinar, actually, and one of the things people ask me is, are we going to mandate it for all of our essential health workers, while people seeing patients? And I know you mandate in New York, we mandate influenza for health workers, influenza vaccine. I mean, the issue of mandating this vaccine is going to become a big time issue, I would say.
I think it will be very difficult to mandate a vaccine that only has gotten that has received an emergency use authorization, right? The issue about how ethical is it to mandate a vaccine when we don't have long-term data? I think eventually when we have a year's worth of data, potentially, but at that point, we are hoping that people will just do it because, you know, at 250,000 deaths, the more people who die, the more people who would be directly affected, right? Someone you know personally, or someone in your family one of your family members who's died from this. And so I think at that point, hopefully that it will sink in that this is the only way to really get rid of it. And again, even with the vaccine, right? So while you did point out the numbers, that it will significantly decrease the mortality or fatality rate from this disease, but it won't be zero, right? We will continue to see them, but that's why we need effective treatment, right? Or like the antibody treatment. So we will continue to see this for 2 or 3 years down the line, right? We're not going to be clear of COVID-19 as soon as everybody after, you know, a certain percentage of population gets vaccinated. Because again, it's not going to be 100%. There's the 5% of people who may not, you know, respond to the vaccine, and there are people who won't take the vaccine.
So look, I'm going to summarize the answer to the question about what can senior leaders do within our organization. I say it's walk the talk, and, you know, be a great example to this. I have another question on development of immunity. What is the time from vaccination to immunity? And by the way, what's the data just on one shot versus two in terms of building immunity?
You know, I don't know. I mean, I don't. It probably will have some efficacy too, right? I mean, I'm sure it's not going to be 95% efficacious, but certainly, and again, so I will say that it probably will work, but it probably won't be 95%. If it gets to 70%, I'm still happy. But again, the recommendation is to take the 2 doses. Now, the Johnson and Johnson vaccine is a 1-dose vaccine, and so that is something. And they're still enrolling in that trial, and it's still coming up, but certainly we will. It's 1 dose, but it'll be available within 2 months of either Pfizer or Moderna.
But what is
And
the time for immunity development after vaccination?
what was that? Sorry.
How long does it take to seroconvert? How long after you start to develop immunity?
I think within 2 weeks, right? You should see some antibody production just like any other. So the vaccines are no different than the flu vaccine that you get, right? So the only difference is that it actually is an mRNA, which is almost like the tools to make protein, as opposed to the flu vaccine that we inject protein material of the, you know, the flu virus. And I do just want to clarify, I have not done a scientific study on our vaccine hesitancy in our healthcare workers, right? It's just that I'm hearing among our own staff to say that that even the frontline workers are hesitant about taking the vaccine. So we're working on our own messaging as well. So when I'm saying 50%, I'm actually being pessimistic, but I'm hoping that it will be high, right? And then just to clarify about the flu vaccine, New York doesn't necessarily have a mandatory vaccination requirement for flu, but for healthcare workers,
Oh.
it means that if you don't take the flu vaccine, um, you would have to wear a surgical mask the entire flu season, right? Which could be from October to May. So that's just a long time. So that is the initiative that makes people take the vaccine, because they don't want to wear in the regular season, flu season, they don't want to wear a surgical mask. And so unfortunately now everybody's required to wear a mask. So it's not as big of a incentive. But we are actually where our vaccination rate is, even with just that, approaches 93%,
Good.
normally for flu. So
So hopefully we could get the hospital staffs up to 90% plus.
yeah.
Okay, I have a question from Florida. They're seeing a
Mhm.
48 to 72-hour turnaround time on PCR. Given the limit of a 5-day window for the antibody infusion, can a positive rapid antigen test in a symptomatic patient be an alternative to the PCR?
It is. So we are willing to accept that, especially if you have symptoms. An antigen positive test would be fine. The problem is you do have to have a positive test, right? You can't just have a symptom. So if you have access to a PCR, I know that sometimes the results are delayed compared to antigen testing. We do need a positive test, though. That is the only thing. And you may have a 20% decreased sensitivity of the antigen test compared to the PCR. So that's why I'm recommending the PCR. But we will also take a positive antigen test.
Just for a little pitch for EHE, we're providing PCR tests, sputum tests for many companies, and
Yeah.
our turnaround time, they're generally FedEx, they're sent to homes. Our turnaround time is generally is 24 to 48 hours. They can
Then
call you Dr. Pensabene, right? If
yeah.
Yes, we will have that all set up.
Yeah, we have that pretty much set up. Okay, so I think I have other questions more about the epidemic itself.
Mhm.
I have a question here about travel. We're walking in, obviously, into the travel season. Since most people won't have the vaccine until 2021, what are the recommendations? Maybe Dr. Pensabene, you can mention a couple of things that we're recommending about travel and kind of how to conduct yourself safely.
Especially given the recent surges that we've seen in the case counts across the country, we are continuing to encourage avoidance of non-essential travel, whether it's across the state line or, global international travel. So staying home is what we recommend. If you do have to essentially travel, keeping a close watch on the guidelines and continuing with all of the precautions that we spoke about earlier. Really, they're ever changing in New York State and how to test and how long to quarantine for essential travelers as well as non-essential travelers. So really understanding what those guidelines are and how to keep yourself safe if you do travel. And my family, David, this Thanksgiving, we're not even going to see our family. We're going to do an immediate family Zoom Thanksgiving with those in our extended family. So really trying to stay close to home and leading by example in between these two holidays to try to keep the numbers down.
I think a sensible approach is you need to pretend that almost everybody is asymptomatically shedding virus and just behave and conduct yourselves appropriately, whether that's in a hospital or what. And if you think about it that way, I think that you can have a reasonably good chance of staying safe.
Yeah.
And the other thing I thought about this, because even if you're not a high risk person and you think that, oh, I'm okay if I get the COVID-19, I'll be fine. Well, number one, you may be seeing your parents who are not, right, or grandparents. The other one, though, that if you ever travel to a high risk area, and if you get COVID-19, you're stuck there for 10 days. Or if you get exposed to somebody who has COVID-19, you're actually stuck there for 14 days, right? So those are other things, especially if you're going to a really high risk area where the positivity rate in Wyoming was 91%, right? So 9 out of 10 people who are getting tested, mind you, maybe they don't have testing available as much as it is here in New York. And even though we have great testing here in New York, I don't think it's enough, right? And we still have long lines for getting tested. But 91% of positivity rate is truly, I never thought we would see that, right? So,
Yeah, it's amazing.
Yeah.
I have another question. This is about actually testing and the insurance coverage on tests. I mean, people in New York, we say, you hear the ads all the time, it's supposed to be free. And we hear, and our employers complain all the time, their patients, it's not really free. They're charging for services, even though not for the test. Maybe you could each say a word about what is the coverage issue these days on testing? I know it's different in different jurisdictions in different states, but maybe Cara, you could start by saying in general what we're seeing in the country, and maybe Dr. Camins, how you're dealing with that at Sinai.
And I think you summarized it pretty well already, David. In theory, testing should be free. Symptomatic, asymptomatic testing, it is supposed to be covered by health insurers and covered, by the local health departments. It is not what we're actually seeing in reality. It depends on who did the test, where what type of test was done, and whether or not you met criteria for symptoms or the reason for the test.
Right.
And that is really why many of our clients are opting with a program like ours, David, where we can ensure that they are getting the appropriate test for a clear price. It can, if bought by consumers, can be charged to an FSA or HSA. So we're not really seeing free testing across the country. And this is sad, but it is reality.
Yeah. So the only access to free testing would be if you go to a public health or a city or a government or a state facility, right? Then that would be free. But the problem is turnaround and the lines are long. Technically, if your insurance covers it, no one can charge for copay for COVID-related illness, right? So if your insurance covers it, and the key is that medical necessity, right? So definitely, if you're symptomatic, that is a medical necessity. If you were had a high risk exposure, that is qualified, right? It's medically necessary. Unfortunately, the asymptomatic periodic testing may be where you might run into trouble because you wanted to go see your parents or someone who is at high risk. You wanted to get tested. Those may not be covered, and there might be a hard time justifying that getting covered. And again, I do want to warn, because a lot of people are doing this, is that they're going to go get tested before going to see their parents, which then they say, oh, I'm safe, right? That is not true. A test is only good for that day, right? Tomorrow you could be contagious because you just got tested during your incubation period where it's not detectable yet. So getting tested gives you that added safety, just makes you feel better when you go see you, but you should still social distance, wear a mask when you're with them, and do not share a meal with them if you had, potentially had some high risk behavior, like, being involved in a large gathering, right? Indoor dining. If you had did some of those things in the last 2 weeks, then I would say you can get yourself tested, but do not share a meal with someone who's at high risk. So.
Okay, we're at the top of the hour. There's 2 or 3 more questions we're not going to be able to get to, but we'll make sure we answer them anyway. We'll answer them individually. But one of the questions I will answer, which is, yes, Dr. Pensabene's slides are available after the webinar, no problem. I want to really thank Dr. Camins and Dr. Pensabene. This was a fascinating discussion, and I hope it's a hopeful discussion for people. And it's a mobilization discussion, and it's something that we can all think about and work towards in the next 6 or 8 weeks. And sometimes you have to be in the blackest hole before you see the beginning of light. And I do believe we are on that path. We have a COVID resource center. It's at covid19.ehe.health. We have our current line. It's still up, 844-258-1820. You heard Dr. Camins' gracious offer connecting people to therapies, and we'll be happy to do that. Our next webinar is going to be on some of the regulatory issues around the advent of both treatment and immunization. So I just want to thank you both again. I think this is a really fascinating discussion, and in good health for everybody. And hopefully this is going to be, a turnaround event in the next few years, in the next few weeks. So thank you both very, very much.
Thank you.
Thank
Okay.
you.